Um, So for everyone online, we're just going to get going, but Dr. Kavesi just came, so we're waiting for him, and now we can get started. So I want to welcome everyone to Pediatric Grand Rounds. We have a special visiting speaker today. I'll start with an land acknowledgement. Ottawa is built on the unceded Algonquin Anishinaabe territory, and the peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. I was actually delving into that millennia. It's actually like a lot of millennia. I always like to understand what I'm saying, but it's an interesting history to dig into. So I'm very pleased to welcome Dr. Hemant Sawnani from University of Cincinnati in the pulmonary medicine and section of sleep medicine. He's a pediatric respiratory and sleep medicine specialist embedded in the comprehensive neuromuscular program at Cincinnati Children's Hospital Medical Center. He's a professor of pediatrics at the University of Cincinnati. His interests are pulmonary physiology and mechanics, respiratory control, and mechanical ventilation. He maintains an active clinical and research interest in neuromuscular pulmonary and sleep medicine, thoracic dystrophies, respiratory mechanics, and the care for children dependent on related respiratory technologies. And he's also good at writing a bio because I didn't have to like skip over anything because it was like 2 pages long, so it was a perfect bio, so I appreciate that. His topic today is respiratory changes in neuromuscular disease. So thank you.
Thank you all for inviting me and having me here. Just before we begin, I just want to make sure that folks online can hear me clearly. If anybody can just say yes.
Yes.
Beautiful. Thank you so much. At least an N of one is listening. So I have no disclosures. And, for today, what I wanted to do was really, I took a very clinical approach to this, as I heard that there was going to be residents here, and I didn't want it to be too technical. But at the same time, I'd like for you to be able to take a little different perspective when you look at your patients who come to you either in a wheelchair or, when you have cerebral palsy patients. And to begin to try and learn how do you anticipate changes that are going to take place over time, either with growth or if there are any tipping points that are going to bring this patient in respiratory insufficiency. So, we're familiar with these basic relationships that go back to Gray's anatomy, where you've got 12 pairs of ribs that articulate with vertebral bodies. But I think the most important thing here is that the ribs are not there to protect the lungs. I think it's to enhance respiratory function. And I'm going to show you some examples by which I would like for you to walk away from this understanding that if these ribs do not maintain this form, then you're not going to maintain good function. So this chest wall is actually a multifaceted, multi-jointed structure that allows for movements in multiple different dimensions. At a functional level, when you think about the drive to breathe, it originates in the brainstem. But you can modify and regulate that differently from the cortex with conscious input. So you can decide to hyperventilate or hypoventilate intentionally up to a point. So all of that drive translates into impulses that come down the spinal cord and activate the diaphragm as well as intercostal and abdominal muscles. So you're familiar with that. But in order for all of this to be effective, you have to maintain a patent upper airway. So the role of the brainstem is directly also involved. The brainstem is directly involved in regulating tone of your upper airway muscles. If you've ever seen infants with SMA1 back in the day, or sometimes they're probably about 15, 20 years old, perhaps, these were patients back in the day who couldn't even maintain a patent upper airway even awake. And then you have a bunch of feedback mechanisms that range all the way from the brain, looking at paraventricular and pH receptors as they respond to changes in pH, along all the way down to upper airway pharyngeal receptors, carotid bodies looking at O2 receptors, and of course you've got stretch and irritant receptors in the lung. So there's a lot of feedback mechanism that goes into, hey, you need to stop inhaling so that you can exhale, that kind of thing. So when you put all of this together, you get a tidal breath that expands the chest wall. When it's a loosely term, we use this term loosely. When we say expand the chest wall, what we really mean is there is an increase in lateral and frontal dimensions of the chest wall. So when you think about this single displacement of 500 mils of air when you're sitting here in a chair, your diaphragm moves down, produces negative interthoracic pressure, and that's what leads to expansion. So you have the proverbial bucket handle movement of the lateral rise of the ribs, and you've got an increase in frontal diameter of the chest, wherein the sternum moves anterior superiorly, and that's your pump handle movement. But there's the third dimension, which is your diaphragm moving down. And so that increases the height of the chest. So you increase the chest wall measurements in all three dimensions. When you have muscle weakness, consider a patient who is somewhat sedated, you lose pretty much 2 out of 3 with primarily preserving only just your diaphragmatic movement. So I'm going to take you through a clinical vignette of a patient who I continue to follow. And I saw her for the first time at about 2.5 years of age when she had presented with a refusal to walk. And after a few weeks of this getting worse, the parents brought her in, and then she was diagnosed with paraspinal rhabdoid tumor in the cervical spine, cervicothoracic spine. And this was subsequently resected, treated with chemo and proton beam therapy. But she had a very extended stay in the hospital. And during that time when we saw her, they called us to come and take a look and say, hey, what can you offer us? And she looked like she was anxious. She was tachypnic, tachycardic throughout her stay following that surgery, and was desaturating every night into the 70s. She was waking up frequently at night, and mom was like, this girl has not slept. When you examine her, her vital signs, like I said, she was tachypnic, tachycardic. Her saturations in room air was 93, 94%. She was paradoxing and was pretty much hypotonic, paraplegic. She had some movement in her shoulders, but not much. Nothing below that. And the tachypnea actually interfered with eating, communicating, drinking as well. So she landed up with a nasal feeding tube at that time. We got a sleep study, and that revealed fairly severe obstructive sleep apnea and an AHI. So that's the amount of it's the frequency of respiratory events per hour of sleep. It was about 14, so you can figure every 3.5, 4 minutes. But in dream sleep, in REM sleep, that doubled almost to every other minute. And like I said, she was tachypnic. She didn't have hypoventilation. Her CO2 was okay, but she was desaturating to the 70s to 67% in sleep. Her CT, when we looked at it upon at that time, this is just right before resection, and you can see here a lovely. I'm going to see if you can see the mouse. That's your lesion right there. That's the airway. You can appreciate fairly normal configuration of the chest wall, and you have a lovely normal lateral to transverse to AP diameter ratio. And we recommended at the time that she need mechanical ventilation. The family decided we're going to go non-invasive ventilation, but then after 2 nights of trying that, they gave up and pretty much refused. Now, here's the thing about being a consultant. I can't tell the primary team what to do. At least that's how it works at our place. So oncology was supportive of just maintaining her on oxygen. And my first preference was she needs a trach and a vent, but what do I know? So a year later, she came back in clinic, and her clinical status had really not changed. She was still tachypneic, still tachycardic, and still having desaturations overnight, although they were still using oxygen at that time. Again, the recommendation was she needs to be on mechanical ventilation if you need her to be able to support herself better. Family agreed, we got her in, we titrated her to the sleep lab, and that one night, I mean, her sleep efficiency went from 65% to like 90%. She pretty much rode her respiratory support. She maintained stable saturations, and she looked pretty good on that. But when they went home, things changed again. So when you think about neuromuscular disorders, we're going to come back to this case in a little bit. When you think of some of, the easiest way to classify this was actually in a paper that I found not too long ago. Well, now it's about 25 years old. They classify them into muscular dystrophies, congenital and metabolic myopathies, like you would see, or, Pompe's disease, Nemeline myopathies, your neuromuscular junction disorders like myasthenic syndromes, peripheral neuropathies, just like the Charcot-Marie-Tooths, and your anterior horn cell, which you also would have said is SMA. But the thing that people don't often think about is the acquired forms. And these, I would say, in pediatrics, there's a number that we see, but we never really categorize them that way. So you have your acute transverse myelitis syndromes, so infection, whether you have it as a bad meningitis, ATMs, post-viral encephalitis. But the others are trauma. Okay, spinal cord injury being high on the list, whether it's tumor, iatrogenic, TBIs, traumatic brain injuries, gunshot injuries, non-accidental brain injury, shaken babies, HIE. So you see that whole spectrum on a fairly probably more commonly than you see any of the forms above. So when we think about respiratory stability, I always like to explain that you achieve respiratory stability when the drive to breathe is normal and you have the appropriate muscle strength or respiratory muscle power to be able to counterbalance the respiratory muscle load. So that includes everything about the chest wall down to the lung tissue, going from superficial to deep. And so any chest wall malformations, thoracic dystrophies, rib abnormalities, pleural effusions, tumors, scarring of lung, anything that increases the inertia to chest wall displacement or lung expansion constitutes respiratory load. So when these two are balanced, you maintain some amount of respiratory homeostasis. Now, this is just a pattern that I have seen, and we never got around to ever publishing this, but when we think about growth in a child who has an early onset of respiratory muscle weakness, you shouldn't miss the changes that occur over time. In fact, I would argue that commit some of these images to memory, because what the red line here, what that's doing is showing you the horizontal opposition or the axis of the rib in relation to the vertical axis of the spine. We always like to see a rib that's kind of upright, looks robust. But as you grow, you would expect that orientation to stay. But when that doesn't stay, and you start seeing that Christmas tree-like pattern, that's how one of our fellows told me, where your ribs start having a disinclination with respect to the vertebral axis, you need to think that this is probably a myopathic chest. Okay? What that's a sign of is that the body is growing, but your lung volume is not increasing. Okay? So what happens when you keep growing? Again, this is another patient with SMA2. At 18 months of age, came on respiratory support, non-invasive ventilation. And actually, I don't know if I mentioned this earlier. This was also one of our SMA2 patients. And what you see over here is with continued growth of the body and the vertebrae want to expand, so you're trying to achieve some sort of thoracic height, but the lung volumes don't allow for that. And then you start seeing buckling. So it's really a nice chicken or the egg situation in my mind. Is what came first? Is the muscle weakness leading to scoliosis? Or is it low lung volumes and then asymmetric compliances of the chest wall. So when I try to think about that to answer that question, this is a lovely study that talks about the differences between the wild type and the muscular dystrophy with myositis mouse model. And this mouse model, the two of them show phenotypic similarities at about 2 weeks of age. But at 6 weeks, because these are fairly rapidly growing animals, there's significant differences, lots of wasting and kyphoscoliotic deformities between the two. However, the interesting part of this was, the micro CTs that they did on these animals. And so when you look at the sagittal view, you see at 2 weeks of age on the left, fairly comparable approximation of lung volumes and diaphragm cross-section in the actual view between the wild type and the MDM phenotype. But at 6 weeks of age, you see a marked difference, not only in the diaphragm footprint, but also the chest wall deformity. So, as I think about this, I cannot help but start thinking that the chest wall is maybe not just one unit, but maybe should be, in some situations, may be considered to be consistent of two hemithoraces that clearly have two very different physiologies over here. Okay, we tend to, when I explain to families what the chest wall does, is, and approximates to, I explain it in the form of, taking a syringe and a plunger, and you pull the plunger down, and that's what draws air into the chest. So that really makes sense as it relates to it being as one unit. But when you think about this, you now have a diaphragm that is really somewhat flat on one side, but really torqued on the other side because of the degree of rotational deformity on one side. And as a result, you have a couple of things occurring. One, that excursion of the diaphragm is limited. Two, you already have chest wall and bony changes. So as a consequence of that, what we say is the compliance on that side is lower. So if the effort on that diaphragm is lower and air takes a path of least resistance, it's a basic principle in physics, then air is going to flow primarily to the side which is better inflated, just because those ribs are going to be easier to move. And then you start having a rather progressive issue over here, where if we constantly reduce our degree of stretch on one side, but we promote it more on the other side, I feel this can at some point just begin to accelerate that rotational deformity in these patients. And, we typically will see that once scoliosis starts in these cerebral palsy patients or neuromuscular patients, it tends to pretty much accelerate whenever we get rapid growth. So how important is tidal volume, right? So if you were to think about the average adult taking a 500 ml tidal volume, a small amount of that goes to your dead space. That's the part of conducting airways which does not take part in gas exchange. So that's, when I explain this to families, I talk about entering a hospital, going through the hallways, and finally getting to the room to see us. That's where the most important part of the visit is. So your alveoli is alveolar ventilation is about 350 ml of that 500 ml. If your tidal volume continues to drop, that dead space is still going to take its pound of flesh. And what you land up with is a much more greater reduction in your alveolar volume. So if your tidal volume went to 300 mLs, 150 ml is still going to be your dead space. You're now left with the remaining 150 ml in your alveolar volume. So although your tidal volume decreased by 40%, your alveolar ventilation reduced by 57%. So, I think about the consequences of increasing respiratory load and how does that look like for these patients. These patients typically, whether it's your CP patients or your myopathic patients, typically have a baseline of upper airway instability. And we know that upper airway instability increases at lower lung volumes. Okay. Lung tissue elastance increases. and chest wall compliance decreases for a lot of these patients. In addition, you throw a little infection, maybe a little increased secretion burden, patients who have difficulty swallowing, can't handle their oral secretions, or they come in for what was thought to be a simple elective procedure, and all of a sudden, in the setting of reduced respiratory drive and muscle power, you precipitate respiratory failure. So, when we think about this whole these convoluted relationships, you can see that everything is really interlinked and often feeds into each other. So it's really hard to separate out what came first. But everything contributes to a worsening. So, it's like, what's the straw that breaks a camel's back? And I think that that's growth. And here's why I'm going to explain that to you. When there is an injury and we see chest wall morphology changes, okay, the degree of clinical insult, for lack of a better term, that we see is a function of what is the underlying disease. Is it a progressive thing? Is it a static injury? What age was the onset? Was this a child born with it, or was this a child who was normal and then had, let's say, a spinal cord injury, unfortunately, at 4 years of age? Is that any different from someone at 24 years of age getting a spinal cord injury? Yeah. So although the insult or the disease may sometimes be static, the consequences for children tend to be progressive because growth has yet to happen. And so there is kind of a little bit of urgency to approach some of these pathologies really early with support, with the idea that we don't want to just have them sustain growth normally for like a few years or just normalize your gas exchange. But it's taking a trajectory view of what do I want this child to look like a decade from now? How am I going to get this kid to prepare for puberty or for accelerated growth at that point? So, the first image on top was, and both these children are about the same age now, in their 20s, but the first one, in the late teens, the first one on top is a boy with SMA1, whose family insisted that, no, we're not going to trach and vent, we're only going to non-invasive ventilation. The second is the same patient, the row below that. And the difference between the two, both are SMA1s, is that, it's a myopathic chest, but the one on top does not have the severe rib deformities that the lower one has, right? That was a family that actually agreed to trach their infant in the NICU and said, we'll take care of him. And I tell you, this child, who's now 17, has never been admitted to the hospital for a pulmonary exacerbation and only came in for growing rods at about 6-7 years of age. So, versus the one on top who's racked up a fair amount of frequent flyer miles. So, when we think about chest wall morphology, remember I told you that rib deformities is something? So, this is an 8-month-old, the image of an 8-month-old on the left, who presented to our clinic with a trach, but no machine. And she has congenital myopathy, an RYR1 congenital myopathy. And she looked like she was going to die. So her CO, we rushed her to the pulmonary unit. Her CO2 was about 78 on her initial gas. And she was just maintained at home on a little bit of oxygen. She was lethargic. All we did was hook her up to a ventilator. And what do you see with the chest wall morphology change at 3 years of age, right? So this got me to think air exerts pressure. And we think about, and a classic example, adenoid facies, right? You see this in books, children who snore, adenotonsil enlargement. What is it telling you? That if I have chronic mouth breathing and I don't have transnasal airflow, I'm not going to stimulate maxillary bone growth. Okay? Children who are born with one lung develop scoliosis even in the setting of normal strength. So that tells you that air exerts pressure. I mean, for heaven's sake, air moves submarines, right? And planes. So it's got to have some sort of trophic effect on us. So with the right pressurization, my hope is that when I look at these kids, is that I want them to have normal form because, God willing, if there's a treatment down the line, it's going to be much harder to support, you know, a rescue treatment over here in this situation when you have such deformity than when you have good form. And it's the adage, the age-old adage, with good form comes good function. So, how do you assess these patients? Of course, there's the clinical part, which we'll talk about in a little bit. But growth charts don't lie. Okay, when you look at these kids, I think that's something that you should look at from the point of trajectories and trends to highlight to you, does this individual have a propensity to get into trouble? It's going to start with a propensity with some sort of indicators of failure to thrive. When we look at specifically at pulmonary testing, we can do testing awake, which is spirometry, lung volumes, things like that. We also do testing asleep with sleep studies. Now, you can get away with some overnight oximetry. But, when you think about sleep studies give you an idea of what the EEG looks like, how much sleep disruption there is. You can see the events that contribute to desaturations. You get an assessment of your carbon dioxide levels. You get a really good 360 view of this patient's breathing physiology in sleep. The only thing you get with pulse ox studies are instability in saturations, and you kind of guess, well, this probably looks like progressive REM sleep disturbances, but you're really not sure how much of that is motion artifact, how much of that is motion artifact from an arousal that may have occurred with an obstruction. You can get heart rate data, but it's just going to show you some accelerations over there. So if you're really considering novel therapies and you're considering deeper evaluations of your patients in order to get a better idea of what to expect in the longer term, nice to have sleep studies. So what happens when we go to sleep? So this is a study that was done in adults. I like the study because I tried to answer a very simple question. What happens with minute ventilation, which is tidal volume multiplied by rate, when you go to sleep? And so we all say that when you transition from awake to different stages of sleep, you experience a reduction in minute ventilation. Makes sense. Your metabolic rate is lower, your oxygen needs are lower, your CO2 production is lower, you're rested, and your demand is low. So the body doesn't need to maintain that same level of respiratory function. So that little 10% decline in minute ventilation is characterized and it's sort of balanced through the remaining part of sleep. But when you look at them through individual stages, you find that the tidal volumes tend to be at their lowest in REM sleep with a rate that is highest. So REM sleep or dream sleep is your state of respiratory muscle atony. It's nice to know that you have muscle atony in sleep because otherwise you would act out all your dreams and your bed partners would not be bed partners after a short period of time. So it's important that we maintain some hypotonia during sleep. But there is sparing of extraocular and diaphragm muscles there. So when we consider REM sleep, we see two parts of REM sleep, where you actually have rapid eye movements, that's the phasic REM sleep, or tonic REM sleep where you don't have that. Simplistic put. And there are significant differences in that phasic REM sleep is the state of sleep where you have the highest degree of respiratory instability. As it relates to sleep architecture, which means what's your sleep quality as you go through the night, with individuals with muscle weakness, and with a lot of this information also comes from adult spinal cord injury patients, we see a reduction in total sleep time and sleep efficiency, meaning they get into bed, they have a harder time falling asleep, and when they fall asleep, they tend to experience a little more light sleep than deep sleep. There's more sleep stage shifts, what we call sleep fragmentation, in these patients. And when it comes to the respiratory patterns, you see a lot more paradoxical respirations, even without narrowing of the upper airway. So what we like to call non-obstructive hypopneas in these patients. And these things tend to be really amplified, as I mentioned, during REM sleep. Why do you see so much more saturation instability during that time? Because one, patients typically tend to have a higher risk of hypoventilation in that time. They also have repeated apnea-hypopnea events or instability of the upper airway contributing to those apneas. And these patients may also have some VQ mismatch from ventilation perfusion mismatch in the dependent areas of lung, which are a little more magnified when they go to bed. And the lower the saturation nadir generally, the saturation nadir decreases as disease progression increases. So regardless of what management you take in terms of whether it's pressure or volume cycled support for these patients, your goal is to normalize breathing pattern, not just normalizing gas exchange. If you were just to hang your hat on gas exchange, you will often find patients who can be weak, symptomatic, and still maintain reasonable gas exchange just because there's so much sleep disruption. If there's an apnea that wakes an infant or child up, that arousal response actually protects them from a very significant desaturation. So if you just rely on that, and some of them are tachypnic to start with, so they may not manifest hypoventilation until they really fall off the edge. By then it's so late. So the important thing is to try and catch this in motion. All right. So regardless of the mode that we pick, the bottom line is you always use bi-level support. It doesn't matter whether it's pressure or volume cycle. So when you think about normal tidal breathing schematically, in patients with muscle weakness, we start seeing rapid and shallow breathing, and that often becomes the first sign of respiratory insufficiency. The second part is, what do you need to do to normalize that? So you need to normalize not only the rate of respiration, but you also need to normalize the depth of respiration. And so for you to normalize the depth of respiration, you have to use bi-levels, whether it's positive or it's volume or pressure cycle again. In bi-levels, the lower arrow provides you expiratory airway support, or PEEP if you're on a ventilator, or EPAP if it's non-invasive ventilation through bi-level support. And that only helps stent open the airway. So if you think about obstructive sleep apnea in the general population, yeah, you can manage that with just continuous positive airway pressure because there's no dearth of respiratory muscle strength there. But when you have a problem achieving an appropriate tidal volume, that can actually get magnified if you only provide CPAP and not provide the driving pressure required, and when patients don't achieve that peak pressure, they're not going to get an appropriate tidal volume. So essentially the area under the curve is kind of the tidal volume. Okay. Now, when the body gets a nice, good, deep breath, it's going to say, well, I don't need to breathe anymore until hypoxia or hypercapnia kicks in. So it's really important that you provide a physiologic backup rate for these patients. Images of lots of ventilators from past to present. And then there is, the negative pressure ventilators from the polio epidemic back in the day. Then you've got the current version of a negative pressure ventilator, the HIAC. There's only one company that I know makes it, but that I've seen. I guess there are a couple of others now. A couple of home ventilators, mechanical ventilators, and then you've got a smattering of non-invasive, what we call respiratory assist devices that don't have built-in batteries. So what's the role of mechanical ventilator support in these patients? And how do you measure impact? This is one of the earlier studies that I think just really succinctly provided that answer. And on the left are a series of graphs of 7 patients with SMA1 that were studied in the sleep lab at baseline before the initiation of support, and again 6 months later after. And the images in on the left actually show you a series where all patients seem to have appreciated improved sleep efficiency between before initiation of non-invasive ventilation to 6 months later. improved deep sleep and improved REM sleep, and saw a overall reduction in light sleep, what we construe as sleep fragmentation. And then the qualitative impacts were measured through questionnaires, so family and the patients, and these were, questions surrounding sleep disturbances, nocturnal sweating, morning headaches, nausea, impaired concentration, and a summative score. And you can see that in general, all patients benefited by the institution of non-invasive ventilation 6 months after that. So this has kind of been a little bit of a more recent reckoning for me as I think about where I would like my patients to be in certain periods of time. So when you think about the normal growth of a child will learn to roll, first head control, rolling, sitting, pulling him up to a standing position. What you're seeing is progressive increases in truncal muscle tone and control. That is then followed by improving physical activity, from walking to running. That is also associated with getting louder, right? Think about a toddler, an infant, a newborn infant versus a 4-year-old. Who can have a louder tantrum, right? But what you're seeing is an improvement in respiratory muscle strength and lung volumes. If a child can yell for multiple seconds in a row as opposed to a short, brief cry, that's an important indication of improvement of lung volume, because it's taking you longer to empty that lung with amplitude. So as these kids grow, you expect strength and lung volumes to kind of grow in tandem. What happens if you get growth but you don't get strength, right? So, homemade graph, just to give you food for thought. When you think about, let the black arrow be normal. I probably should have done some zigzags with that, because you see improvements really between like 3 to 5 years of age, where you see a lot more increase in strength and activity of the children. Then they go through school, and then the prepubertal growth spurt, right? And through puberty. So these are really those big, large time points where our kids typically get into trouble, especially with neuromuscular disease. The metabolic demands are higher, growth demands are higher. And, activity also is changing at that time. So the green arrow, in my mind, is the child who kind of has his weakness, but still moves along. So whether this is someone with a mild myopathy, but still functional. So he or she may never achieve the capacity of unaffected peers, running track, all that. But they will still continue to grow and gain strength, gain height, be fine. The one in red is the one where strength plateaus out, but growth continues. Okay? So what happens there? And this is true for like our, metabolic myopathies, Nemelines, Pompei's disease. You can rescue them up to a certain point, but their strength never really increases past a certain limit. But if you continue to grow the body, you start increasing mass. When you increase body mass, every cell is metabolically active. That consumes oxygen, produces CO2. So if your lung capacity is limited, that CO2 has to go somewhere. And if it's not going to be exhaled appropriately, you start getting compensation. So when you think about progressive growth in these children and thinking about the importance of maintaining good lung volume as they grow begins to hopefully take a little more concrete shape in your mind. Now, the last thing I'm going to tell you. For that graph in red, even though the strength may plateau, so the neurologist will tell you his hand grip strength is the same. But with growth, you're not really going to increase that much mass in your hand, but you're going to increase mass in your shoulder, in your trunk, in your legs, in your hips. So what's going to happen is, even though the strength stayed the same, it might look like your patient is regressing just because you're increasing the resistance or the mass for the patient, but we're not increasing the strength. which is what normal growth would have done. So if you took the gallon of milk or liter of milk, how to catch myself, right? And you hold it close to you, you can sustain that position for a lot longer than if I asked you to hold it like this without any other compensation. That mass has stayed the same. Your mechanics has changed. And that's exactly what drives a lot of the pathology in these patients, particularly as it relates to truncal pathology. So, when you, like I said, this is that same 8-month-old and 3-year-old we talked about. This was her image. And you see that bell-shaped chest? You've all seen this when you look at an X-ray, right? But today I'm going to give you a 3D view of what that bell shape looks like. And that's the image 3 years later, 2.5 years later, when all we did was hook her up to a ventilator, right? So look at what has happened is you've filled out the lateral aspect of the chest. It's much more normal shape. You still have a little bit of a de-inclination of the ribs, but at least they're normal in configuration. And look at this precordial, the sternum is just collapsed on this chest, and you've really established a nice precordial shadow, right? So our radiologist really had fun. I typically like to get a CT of my patients so I know what's going on. And he was so profoundly affected by the image he saw and the change. So this is, I was not able to demonstrate that here, but I have the image of the 3D CT actually being rotated. And it's really lovely to see how this lateral chest wall is so retracted in the earlier images. And that's what increases your AP diameter, right? So an increase in AP diameter is not favorable for the chest wall when compared to the transverse diameter. Like, for example, coming back to our case over here. So this is, again, Elena, lost at 6. She was lost to follow-up after I saw her at 3.5, and I still made the recommendation, you need non-invasive ventilation. She disappeared, didn't use her bilevel, and came back just only using oxygen. And this is what she looks like now. So this was a CT done a few months ago. And you can really see how her C-spine and the cervicothoracic spine is collapsed. And there's profound weakness. You can hardly see any chest wall muscle. There's some sparing of around the supraspinatus, but you can see her vertebral body has moved to her left hemithorax. And she has a really hypoplastic lung on this side, somewhat preserved. And, it's kind of sad. In my mind, some of this is preventable, right? But you cannot save the world, right? We always find out that. That's her growth chart. This is where she fell off right when we saw her in the hospital early on at 2.5 years of age, 2.5 to 3. And she really never regained that weight and has progressively been losing deciles. So right now, plastics actually called me the other day and says, we want to get her into the OR because we got to put spacers on her back, under her skin, to grow the skin over those spacers that they will inflate so that she will have some space to finally approximate her when they do a spinal fixation. I said, how do we think we're going to manage this in terms of recovery? You need fat and proteins, and nutritionally you need to be rehabilitated if you want to heal from scoliosis surgery, right? So when you look at your patients, keep an eye on time. As you see your patients coming to clinic, look at them as you walk in. Your examination starts as you walk in. Is this someone who walked in, limped in, got crutched in, or who got rolled in on a wheelchair or bed, right? Head and neck, look for craniofacial changes. This young lady on the right, she's one of my congenital muscular dystrophy patients, a Merrison patient, deficient patient, and she's got mid-face hypoplasia from chronic nasal mask ventilation. But look at her jaw. Her jaw is actually prognathic. She's forward, not retro. And that's largely because of the mid-face pressure from non-invasive ventilator use. Why is this important? Because if you're going to consider a mask for a patient, you need to know Does that jaw open or close? Can they actually approximate that mouth enough to maintain just nasal ventilation, or will you need to go to a full face mask? Is your patient drooling? Well, if your patient's drooling, you're less likely to want to put a full face mask on because you're going to push all of that into the lung instead of letting it come out. What's their voice like? Looking at that tonality, the clarity. I worry a little more when I have patients who have that gritty, grainy voice because that tells me there's a subtle amount of aspiration going on. How fast are they speaking? A lot of my older Duchenne boys who have been in wheelchairs for over a couple of decades, will try and get their words out softly and quickly in between breaths. How's the neck mobility? Look for normal curvature. Kids who don't have normal cervical lordosis worry me because I need to then later, I worry about how the airway looks from an anesthesiologist and from an ICU point of view as to what extubation could look like for these patients and if you corrected them. This is a patient of mine. This six-pack abdomen is really not because of, working out. That's pseudo-hypertrophy. I hope it's clear to you guys. It's very clear over here. But look at the shape and size of the chest. Always lift the shirt. Don't do your first examination. Do not do it over a shirt. Look at the tidal breathing of this patient. Maximal respiration as well as normal tidal breathing. You might see normal engagement of the chest wall awake with maximal respiration, but tidal breathing could just be belly breathing for these patients. And that's kind of, to me, that's an entryway or a gateway into kind of hypoventilation and sleep. Look for paradox. What does the spine and chest look like together? And then look at the extremities. Are these patients prone to contractures? If these are patients who cannot straighten their elbows or wrists or fingers or cannot flex them, you got to think that this is contracture related and this is likely going to translate into similar manifestations at costovertebral joints. So this is a patient of mine who had 100% respiratory muscle strength and 100% lung function. He's got Duchenne muscular dystrophy. And then I asked him to take a deep breath, right? And you see no chest movement, right? So this is the guy who actually, with 100% lung function, actually had pure hypoventilation on his sleep study. And the only reason he got the sleep study was we looked at this and if your chest is not moving, we're going to get in trouble. So as you look at your patients, I'm going to leave you with just tripping points for your patients. Where are their vulnerabilities? If you see a patient who looks like he's got a wheel in a wheelchair or has come to you with some hypotonia but is failing to thrive, right? That's a red flag. What's going to happen to my patients who have muscle weakness if they have a fever, right? Remember, we talked about you need to be able to increase your minute ventilation with a fever. Right? We all do that. We breathe deeper and we breathe faster. But if you can't breathe deeper, you're only left with breathing faster to match the metabolic need of a fever to 38, 39 degrees centigrade. So think about tripping points for your patients. Respiratory illnesses. Everyone looks great sitting there talking to you, but when someone gets sick, that's when the rubber meets the road, right? And then look for comorbidities. What's your salivary control? Your patients with cerebral palsy, are they drooling all the time? Your normal swallow is about 300 to 500 times a day. In patients with muscular dystrophy and muscle weakness, that gets cut down to almost 30%. And we use so many treatment modalities to reduce the amount of salivary volume. So we actually land up thickening the saliva. The mucin content is not changed, but the aqueous content is changed. And so we need to pay attention to what we're doing as what are we treating and how are we kind of cementing that for the patients. Look for developmental delays. These are patients who will not be able to tell you, hey, I wake up a lot at night or my head hurts in the morning when I wake up, right? They won't be able to complain of insomnias. Patients with muscle weakness, whether spinal cord injury or so, one of the first signs that they are probably not having good respiratory function is insomnia. Look for scoliosis, seizures. These can complicate salivary secretion management as well as respiratory management. And last but not least, cardiomyopathies, right? Because all of that does lead to changes in lung compliance, secretion burden, and then leading to failure. So I'm happy to take any questions, but I kept this really clinical and as pragmatic and relevant to the clinician as possible. Thank you.
Great, thank you very much. Yeah, you've got me thinking about several patients, in the past. So I'll open it up to questions. I have a list of my own questions, but any questions in the room or online? Yeah, Tom?
Riddle, thank you for a lovely talk combining the physiology and the clinical. I have two questions. Think about your two hemidiaphragms. They have different loads. I mean, you've got a liver under your right, and then you've got this large lump on the left side called the heart. If you look at 100 SMA2 patients, is scoliosis more likely to be concave to the right or the left? Or there's got to be a reason.
So, Hemant, if you can come and just summarize the question.
Yeah.
And
So that's a really good question. The question is, if you consider looking at 100 SMA patients, are they more likely to have curvatures to one side or the other? Largely because on one side you've got a liver under the one hemidiaphragm, and you've got a heart on the left side. So I feel like the heart is more mediastinum than it is really on the left hemidiaphragm. We don't really see diaphragmatic excursion that impaired early on in SMA1. And I remember this when we had actually done some fluoroscopy for some reasons in patients with respiratory paradox. But I can't say that I have a clear answer, a logical clear answer for you in terms of whether scoliosis is either dextro or levo, because I feel like there's the other part, which is the kypho or thoracic lordosis that some of these guys carry. And I feel like we see a smattering of dextro and levo scoliosis along with anterior posterior shifts. More often than not, there seems to be a kyphoscoliotic rather than a lordotic chest in that type. Now, for some reason, the congenital muscular dystrophies, especially the SEPIN ones, they tend to have a little more rigid spine, straight spine, so they lose their thoracic kyphosis, and they tend to have more of a relative thoracic lordosis there. So just with SMA1, I can't say for certain that there's going to be a shift one way or the other. Compounding that now is the fact that we've got novel therapies, and I don't know how that's going to influence that.
My second question is to get that good lung expansion over time. Do you follow the John Bach method with the very high tidal volumes on positive pressure, or sort of more regular tidal volumes?
So the question is for the online community is trying to establish appropriate tidal volumes and chest wall growth for our patients. Do I take the John Bach method of a high volume delivery? So, I'm going to answer this in two parts. I think there's a reasonableness approach that we have to take. I can't believe that the use of plus or minus 50 centimeters water pressure leads to any higher volume delivery than plus or minus 25 to 30. As we have played with inexsufflator devices and have, in one of our recent clinical studies, I was able to generate on the biomed engineer as well as myself really textbook type pictures of normal pressure volume curves at 15 to 20 centimeters water pressure. What we changed was the inspiratory time. So you can actually deliver maximal volume at lower pressures, and I've taken this, and I find it more successful in lung recruitment when I increase the inhalation time to like 2.5 seconds of inhalation. at a pressure of 24, 28, in that range. And when I look at the number in terms of especially on the Respironics, the T70s, the cough assist machine, you can actually see volume delivery roughly there. I think it looks larger when you have high pressures because your leak is larger. So the higher pressure only means a difficult interaction with the patient, I think. It's more uncomfortable. I'm worried about gastric distension. So I take and even for patients who've come and de-recruited a lung in the ICU, when they have had difficulty recruiting and calling us for bronch, I've said, why don't we change our technique here? And almost always we recruit the lung within 24 hours with lower pressures and a longer time.
Blew that one out of the water.
So.
Thanks. Joe Reisman made a comment that he blew that answer out of the water. I followed most of it, I think. I'm going to ask one of my questions, and I was very intrigued by the hypothesis around growth. And so, that led me to a few questions around that. So one was, if growth is a proximal cause of some of the disturbances that you're describing, both structural and mechanical, and especially in the acquired causes, whether it's trauma, tumor, etc., would comparison with adults who are done growing, who have a similar cause or injury, be helpful to test that hypothesis? So, for example, do you see any similarities in the pattern of what happens in someone who's finished growth at the time of the injury or the tumor with what you're seeing here? And if you do, why? Or if you don't, then that might support the hypothesis. So I was curious about the adult similar.
So that's a really good question. I'm not aware of any studies that have done that, but and I think it's simple to do. Although I think we would have to actually actively withhold certain therapies, which I have a problem with philosophically, to really test that. Because the adult never had any issue and grew normally until, an unfortunate injury. But because growth is done with, you don't see those rib deformities. They may or may not even develop scoliosis because the curvatures are pretty established and spines tend to get pretty stiff. But in a child who's flexible and growing and still has, and think about children who are weaker also tend to have more osteopenia. So I think those ribs tend to be far more deformable, like our SMA1s or congenital myopathies, and neonates who are that symptomatic. That I find it hard to believe that we would actually. It's really rare to have no chest wall or spine deformities in kids like SMA1 where the insult is early, and definitely not, I think, in spinal cord injuries later on in infancy or childhood. I haven't seen a single child who did not develop chest wall or spine deformities. So I think growth has a big role to play in that, but I think the other part is the strength of the bone itself to start with, just because of the relative osteopenia they have at that, if it's an early insult.
Right. And thanks. I have like 3 follow-up questions, but I have time with you later, so I will ask those then. We'll take one more question from Eileen here.
I just was interested in some of the comments that you made about parents not wanting to follow the recommended treatment plan. And I wondered if you had some ideas around the reasons for that, because I think that piece of your talk is transferable to my specialty and other people's specialties, whereas the actual pressure versus volume, it's not going to help me. But I am interested in how to identify barriers to adherence to proposed therapy.
So the question posed surrounds getting families to agree to the therapies, particularly when we make recommendations that I think they perceive to be somewhat uncomfortable. And I think that there is stigma to trach and vent in the community, and it is hard sometimes to overcome that. If you think about it in terms of unit time, we spend a lot less time with our families and patients talking about this than what is available in the palm of the hand from media. And I don't know how it was for you guys, but for us, 15 years ago, to this date, I have a bullseye painted on my back for recommending trach and vents for SMA1 early if family says I want to do everything. And this is largely by the SMA1 communities. I mean, I had a reputation that Dr. Sawnani will either trach them or grave them. That was not true, but the best recommendations take precedent. And I think we have enough of clinical experience to say this is what the outcome is going to look like with each one of these pathways. In fact, we are trying to explore barriers to decision making at our location. And we actually have a team now to approach this for inpatients. We do try to engage the same team for outpatient management as well. And the team comprises of a pulmonologist. We are a few now. It started off with an N of 1. We are a few of us now that engage in this. A pulmonologist, critical care doc, and a neonatologist. And then we have some nursing trach and vent educators as well. And we've prepared like some handbooks and stuff like that. The idea being sitting down with the families and saying, these are our treatment options. All of these are legit and ethical, and we can support that. However, in terms of outcomes, these are what your expectations should be then. And I think in that, we talk about burden of care in the short term and longer term. We talk about quality of life and the ability to go places, do things, and still have good experiences with or without support. And then we talk about morbidity and expected mortality. And I really think it's about approaching it in the best and most unbiased manner and allowing families to make some kind of guided decisions. But it just can't be like, you need to do this, and this is what we say, and this is how it ought to be. But I think there's a lot of relationship building that needs to happen. And with children with chronic diseases, I think relationships really go a long way in getting families to buy into therapies. Trust is like, there's no supplement for that. In fact, I feel like if you never get off on the right foot and you never get trust, none of your recommendations will ever be taken.
So thank you again. I think that's actually a great note to end up on. So thanks to everyone online, and that's Grand Rounds for this week.
Thank you.
Thank you.